Hello, everyone. Welcome to the fourth NABI Podcast. I'm your host, Dr. Queenie. I recently completed my MCH in plastic surgery from PGI Chandigarh and currently doing clinical rotation in burns at Shriners Hospital, UC Davis, California. Today, it's a great honor for us to have Dr. Mark Fisher. Dr. Fisher is an associate professor of plastic surgery at Johns Hopkins Hospital. Sir is the director of Johns Hopkins Burn Center as well. He is an expert in burn critical care and burn reconstruction. And he's extremely committed to the improvement of burn care globally. He heads the International Burn WhatsApp group, which has over 300 burn surgeons globally. The WhatsApp group is a very active platform where interesting burn cases are discussed and inputs are received from all over the world. In short, he's the national and international leader in burn care. So he's received training from all prestigious universities like Harvard, Duke, Hospital for Sick Children Toronto, and Shriners Hospital Galveston. He's significantly contributed to literature, has numerous publications, book chapters. I had the opportunity of doing my rotations under Dr. Fisher for the last month. He's extraordinary surgeon and a very, very kind human being as well. He's very actively involved in research and training of residents and postdoctoral fellows. He's recipient of numerous awards. So the Indian community is very, very honored to have you over, Dr. Fisher, for the podcast. We are very excited to hear from you, your experience regarding the early excision timing. We welcome you, sir.
Thank you, Queenie. It was such a pleasure to have you with us here at Hopkins. And I have to say, from our perspective in the United States, we really admire work that's happening in India, where volumes of burn is so high, and hence the impact of your work is so great. And not only that, your reconstructive outcomes because of your plastic surgical skill is really something that we all hope to learn from. And so I think there's a ton of desire on our side to learn and to connect more with the burn community in India. So thank you very much for having me.
Thank you so much. I had a lovely time at Hopkins as well. So we'll start with the topic for today. So the topic for today's podcast is early wound excision within 3 days decreases the risk of wound infection and death in burn patients. So this paper is from the University of Texas, Galveston, US. It's published in Burns Journal in June 2023. The main author is Dr. De La Torreja. So we'll come to the introduction.
Yeah, if I may say one thing that Stephen Wolfe is on this paper. This is a paper out of Galveston. And so one of the interesting things, I think most of us know Steve Wolfe as a longtime editor and one of the most knowledgeable people about burns that you can find in the United States, particularly about all the minutiae, tiny details about the pathophysiology of burn. And so in this paper will be inherently, he's read 1 million papers about burn. And so his biases and assumptions and thoughts and ideas relating to burn, when he puts together a paper or is involved with it, you can imagine that there's going to be some good thought in there. And so as one reads this paper, looking for his biases and a sense of what he thinks is a very interesting question. So so I'm gonna so please proceed.
So coming to the introduction, the early excision and grafting has become like a standard of practice in burns. This is what introduced by Janzakovic in 1970s. So for partial thickness burns, we can advance this slide. So for partial thickness or deeper burns, we know the treatment is excise the burn tissue. That's the standard of treatment. But the timing of excision is like the big question. It depends on the surgeon, which is influenced by availability of the blood products, the skin grafts, and the clinical suspicion for infection.
Right.
So we can advance the slide in this.
Okay.
So the time frame for excision was defined in a very broad range of 0 to 7 days after injury. So this was according to the previous papers. The next slide, please. So recent studies, they define the early burn wound excision as within 4 days after injury. So, Dr. Fisher, I have a couple of questions. What is your opinion regarding the ideal time of excision?
In general, well, it's probably varies from patient to patient a little bit.
Mhm.
And so our practice here is to start by resuscitating the patient. And then and resuscitation, the acute resuscitation tends to be done at around 24 hours, where the initial instability of the patient and their need for, fluid resuscitation is heaviest in that first period of time. And then after that, we don't have much of a reason to wait.
Mhm.
You know, since they've stabilized and the resources are available, we can safely proceed with large excisions, as 24 hours after the burn. And so in general, our first large excision happens within the first, after maybe 24 to 48 hours, something like that. And then
Okay.
complete our excision. So, one question is, when do you do your first excision? But the other question is, by when do you have the excision done? And,
Mhm.
we tend to have all our excisions done within, 1 week, even in the largest burn.
Okay. How do you determine the adequacy of excision, like the endpoint of excision in case of a deep partial thickness or a full thickness burns?
Well, we're looking for just good evidence of healthy appearing tissue upon
Mhm.
excision. And so that varies depending on whether you're using a sharp excision, if you're doing
Mhm.
excision with a knife, or an exobrid, for instance. So there's different ways to do your excision, and measuring the endpoint of excision is a little bit different between the two. So
Mhm.
with a knife excision, then we're looking for punctate bleeding,
Mhm.
very healthy looking bleeding throughout the tissues, uh, uh, and also tissue quality. So if there are any residual clotted vessels that are present or tan appearing fat, we want yellow, healthy looking fat, clean, unstained dermis, and no coagulated vessels with punctate bleeding throughout, then that is a very good sign. But there are cases where you can have you can have good bleeding, but
Mhm.
a mixture of deeper areas throughout, because
Mhm.
burns are not on a flat plane. They sort of go up
Mhm.
and down depending on the perfusion of the tissues. Um,
Mhm.
but those are key things that we're looking for. And then another thing that we rely upon heavily is the adherence of allograft as a sign of the completion of excision, which you
Mhm.
can't exactly tell at the first operation during that excision. And so there's can be a little bit of unsureness about the deepness of excision in some cases, and that's why we use allograft in some cases to be certain that the excision is complete, so that when we go back for a two-stage, approach, that we can be certain. But yeah, those are some of the endpoints.
Okay, thank you. And what instrument do you use for excision?
There are a lot of personal preferences. Um, some of the options include a weck knife, or also called a Goulian, which is a
Mhm.
smaller knife for tangential excision. There's the larger one, the Humby blade, or Watson blade. And then there's the amalgatome, which is a circular spinning pneumatic blade, all of which have their pros and cons. And then Nexobrid is another option. And each one has its pros and cons and niche. So,
Mhm.
and I have to say, I like all of them for
Uh,
various indications.
Okay,
Oh,
thank you.
I should have also said also the Versajet, but perhaps we can talk about that later.
Okay. Do you take any active measures to avoid intra hypothermia since these patients are so prone?
Yeah, so there are principles, I would say. The one, you only want to expose as much of the body as is necessary to execute the
Mhm.
operation.
Mhm.
And so sometimes, rather than having the whole body exposed the whole time, we'll cover part of it for a portion of the operation, and then and then minimize the amount of surface area that's exposed. And then you can control the overall environment, and hence the heat of the room is one variable. You can control the temperature of the surface area that's exposed. So we have a fluid, a warm fluid surface or blanket that the patient lies upon. We use bear huggers that circulate warm air on the areas that will not be operated upon, or sometimes we'll even cover a part that will be operated upon with a bear hugger, but with a sterile sheet underneath, and take that off later. We use warmed fluids as well, including our blood products. And then another thing is we do speed. The longer you're in the operation, the colder the patient gets. And so we limit our duration of operation. And one of the ways that we can limit the time in the operating room is by increasing the number of people working. So if we have 2 people per extremity, multiple attendings working simultaneously or consultants working at the same time, and between all of these things together, we shoot for a 2 to 3 hour operation, not much longer than that per time, with all of these other adjuncts, and we're able to control the temperature well.
Okay, any specific room temperature that you maintain, the OR temperature?
It depends on the how big we're going to go. So if it's a single extremity, then we may have it at a fairly comfortable temperature for for the people working. If it's a massive burn, then we'll have it in the 80s Fahrenheit. And then we titrate down the temperature based on the patient's core temperature during the case.
Okay, thank you so much. We'll come to the aim of this paper.
Yep.
So the aim was to address the benefits of early wound excision within a defined period of 14 days using an available large database. The author claims that earlier burn wound excision within 3 days after injury improves the patient outcomes. So we'll go on to the methods. It was a retrospective analysis. Data collection and analysis was performed using a large database that was Trinex. The inclusion criteria being all males and females, all ages, who received burn wound excision following burn injury for the past 20 years. We come to the exclusion criteria. Patient who had sepsis, infection, myocardial contractile dysfunction, or blood infusion were all excluded. Then we come to the group stratification. So this patient divided the author divided patients in 3 groups. So first one was 0 to 3 days, second was 4 to 7 days, and the third was 18 to 14 days. So these groups were based on the number of days after injury that the patient received the first wound excision. Short-term outcomes were assessed that were like within 180 days. Death, wound infection, sepsis, myocardial contractile dysfunction, and blood transfusion. The long-term outcomes were assessed within 5 years. So those were hypertrophic scarring and contractures. I have a couple of questions. Dr. Fisher, what measures do you take to reduce the intra-blood loss during excision, since that's one of the major factors during excision?
One of the things is by having a lot of people in the room is really helpful. So plenty of people, and sometimes up to 4 electric cautery devices, so we can work all at once. Number 2, we like to use tourniquets, oftentimes, not all the time, but if we have a higher concern of blood loss, then we'll use a tourniquet. We use epinephrine-soaked sponges that also have thrombin, which we use after you do the excision to put on the extremity. And we have started to use tranexamic acid as a bolus and drip. There's been some interesting data in that regard. We haven't begun to use it universally in our cases, but it's something that we're exploring.
Thank you. Any role of thrombin spray?
Yeah, we incorporate thrombin spray in our soaks.
Okay. So we'll come on to the results. So total patients were 6,158. So we can see that 60% of the patients underwent the first excision within 3 days after injury. 22.5% patients underwent at 4 to 7 days, and 17.5% of patients underwent at 8 to 14 days. Coming to the next figure. So in this figure, we can see 72.5% of the total population had burn size less than 20% body surface area. Out of this, 78.6% underwent excision in the first 3 days. 66% underwent excision in first 4 to 7 days, and 60% underwent in 8 to 14 days. Dr. Fisher, how much body surface area can be addressed in a single setting?
People tend not to do much more than around 30%. Per time would be about as large as most people go.
Okay. Is it the same in pediatric population as well?
It's quite similar, yeah.
Okay. We'll come to the next table. So in this table, we can see on the left side are the number of operations, and the right side is the time for the first excision after injury. So according to the author's finding, delayed excision leads to increased number of interventions as compared to the early excision. Dr. Fisher, what are your comments on this?
So the question is increased number of interventions the longer you wait, right?
Mm-hmm.
Yeah.
Right.
This is a question that we really don't have the answer to, I have to say, because this is a United States cohort, right?
Mm-hmm.
And
right.
It is our sort of accepted teaching that we try to, anyone who is, a burn surgeon in the United States was raised and taught to do early excision. And so why are they not doing this in this particular cohort? Did they have a delay in presentation, or something happened in the course of this person's care where they ended up being sort of randomized, as it were, to a non-standard approach? And so there's something a little bit strange going on that we don't exactly understand.
Right. So we come to the next figure. So this is a 180-day outcome of burn patients with excision done within 14 days. The data is presented. So this data presents statistical comparisons for outcome between patients who had excision at 0 to 3 days, 4 to 7 days, and 8 to 14 days after injury. So you can see in the first figure, the odds of developing the wound infection are significantly lower for those who receive burn wound excision within the first 3 days as compared to 4 to 7 days. In the second, we can see that there's no statistical difference in the odds of all the outcomes between 4 to 7 and 8 to 14 days. In the third one, we can see the odds of mortality are significantly decreased to 0.6 with wound excision in the first 3 days compared to 8 to 14 days. What's your take on this data, Dr. Fisher?
Yeah, so I don't know if everyone who's looking at this will be very comfortable with these odds ratios, but it's important to note that the one is very important. Anything where the data is all on the left side of the one there shows that there is a difference. And so the fact that there is a mortality difference is very significant. But then we obviously think, well, why is there a mortality difference, particularly if there's no difference in sepsis? So the reality is this cohort overall is mostly small, right? With a low chance of mortality at all. And so some of these difficulties and lack of difference may arise from the fact that this cohort has a low chance of dying in general.
Right.
And that, this may be a power issue, but nonetheless, even though their chances of dying overall are low, there seems to be a difference between early and late in the U.S.
Right.
And so so my overall feeling about this data is, yes, there's definitely something here, but how applicable is this to a global audience? How applicable is this to India, let's say? And I suspect that a very important finding, if you can achieve early excision and closure, that patients will do better. But we need Indian data. We need global data. And I think that's one of the main take-home points of this paper is, this is very interesting and I think supports what we're doing in the United States. We should continue what we're doing, but we need more global data.
Right. We need Indian cohort of patients and an Indian database as well.
Yeah, I'd say so.
Yeah. We come to the next slide. So according to the author, if excision is done within first 3 days, the burn wound infection rate is 37.8%. And the findings at 4 to 7 days after excision, it's 42.4% burn wound infection, and which is statistically significant. Dr. Fisher, what is your antibiotic protocol? And do you have any protocol for like blood culture or tissue cultures in patients undergoing excision?
We avoid the use of antibiotics until we have to use antibiotics. So no prophylactic antibiotics, because we know that if we do, that we will have bigger problems later with resistant organisms. So we try to set ourselves up for fewer issues with those organisms. And then diagnosing sepsis in burn patients can be difficult because they're inflammatory. But if we are losing grafts, if we're having very high fevers that are getting into the 40 range, something like that, and if their white count is not very good, but if they're getting multi-organ dysfunction and the wounds are not healing very well, and they're having multi-organ dysfunction, then those are reasons to maybe consider it. Then we're getting blood cultures and directing things based on wound and blood culture. It's worth noting that neither of these are very large. I mean, significant amount of burn, even if it's relatively low. But one of the things you can see here is that the faster you get the burn wound off, the lower your complication rate is going to be in terms of infection. And so I think we should strive to do early excision as much as possible.
Okay, thank you. We come to the next slide. So long-term outcome is assessed, and that were hypertrophic scarring and the risk of contractures. So if burn wound excision is done in 3 days, the risk of hypertrophic scarring observed by author was 22%. If it's done at 4 to 7 days, the risk was 28%. And if the excision was done at 8 to 14 days, the risk was 31%. And that was statistically significant. Coming to the risk of contracture, if excision was done within 3 days, the contracture risk was 30%. But there was no statistical significance, no difference in the risk of developing contractures between any of these three cohorts. I have a couple of questions. How do you resurface the raw area after excision, Dr. Fisher?
How do you resurface a raw area after excision? It depends on how big. So let's say it's a 30% total body surface area burn, then it's going to be split thickness skin grafts in most cases. If it's very deep and we're concerned about vital structures, let's say gosh, it's so broad. Sometimes you may have to be a flap, or you may use some situations we use a dermal substitute. Whether you use a dermal substitute or not, whether it has a salutary effect on the long-term contracture rates and so forth, we don't really have the data to know.
Okay.
So sometimes with dermal substitute, that study needs to be done. Otherwise with skin graft. But in general, if we can make it less meshed, even a sheet graft, we do that, and it just all depends on how big the burn is. But those are the principles.
Okay, so Dr. Fisher, what measures do you adopt to prevent and treat hypertrophic scarring, and how early do you start laser?
Number one, I think the faster you get the wound excised and closed, the better. That's my bias. Because when the wound is open, it begins to contract, doesn't it? And so if you can get the wound closed prior to the start of this powerful contracting period, then that probably helps. However, contracture continues after a split thickness skin graft has been placed, hasn't it? And hence it's the combination of early excision and closure plus early return to physiotherapy and persistent physiotherapy, and plus the use of splinting. Those are the principles. How you exactly work that out is a case-by-case patient and system by system.
Okay. So we come to the discussion. So the author's findings after propensity matching for the patient and injury demographics were as follows. There was significantly low risk of mortality for patients who received burn wound excision within first 3 days when compared to 18 to 14 days after burn. There's decreased risk of wound infection in patients with burn wound excision within first 3 days compared to those who received treatment at 4 to 7 days after burn. The odds of developing a wound infection are significantly lower for those who receive burn wound excision within first 3 days as compared to 4 to 7 days after burn. Earlier burn wound excision is associated with a decreased risk of wound infection, which suggests that after 3 days, the presence of burn scar has already allowed for bacterial proliferation and infiltration, and the removal of scar is no longer as preventive for wound infection. Coming to myocardial contractile dysfunction and blood transfusion. So the early burn wound excision within 3 days after injury did not significantly affect the myocardial contractile dysfunction and blood transfusion. And the highest risk for both was observed during the first 24 hours after. So coming to the conclusion, initiating wound excision within 3 days benefits patient outcome with a lower risk of mortality and burn wound infection when compared to later treatment between 4 and 14 days after injury. The long-term risk of hypertrophic scarring significantly decreases in patients when bone excision was performed within first 3 days, and sepsis and myocardial contractile dysfunction do not appear to be affected. So I have a couple of questions. What is your opinion regarding correlation between the sepsis and wound excision?
In this particular paper, no significant difference in sepsis was identified, right? However, there was a mortality difference, and so this raises more questions than creates answers. One of the things that the authors noted is, well, there's a variety of reasons that people die. One is sepsis, but and sepsis can be the final outcome that leads to it, but pulmonary complications, pneumonia, and multi-system organ failure, pulmonary, liver, and so forth. These are some of the things that we see in the dying patient. Kidneys, liver, lung, and the cause can be via the pulmonary system, or does it happen via the wound? This is not clearly identified by this large court study with this, retrospective data. And so, figuring out why there's a difference in mortality needs to be studied. So it really we need more research, unfortunately. I think there's a lot of need. We can, I think, identify a couple principles in general, though. We know that there's increased infection, and we know that people are more likely to die the longer you wait. Therefore, try to go earlier. However, we also understand, as this paper has shown, that the risk of myocardial dysfunction and need for transfusion is higher very, very early. And so, within the first 24 hours. Therefore, you can't just nonchalantly go into the operating room and assume that your patient is going to do well just because you're doing an early excision. You need to develop the resources necessary to do a rapid resuscitation early on and get them ready for the operating room and then go. So our bias at the moment is to work hard on their initial resuscitation and then go at around 24 hours or slightly thereafter, but not much after. As soon as they begin to stabilize after their initial resuscitation, then we sort of pounce upon them as quickly as we can, get the wound off, and get them closed as quickly as possible. That's our approach at this time.
Okay. One more question. Post cadaver skin application, when is your first dressing takedown, and when should be autograft?
We take our first dressing down a day later, and then in general, we don't have exactly a standard number. We may be going back within a few days. Basically, it's they go through this insult of that first excision, and as soon as they have stabilized again, we go back in. And so that could be 2 days, it could be 3 days, or it could be 5 days. It kind of depends on that particular patient. And then we go back and then we assess the allograft. We take the allograft off, and in the vast majority of patients, removing the allograft, we see, it's ready now. I have to take off a little bit more of the wound here or there, but then you graft at that point. So 2-stage approach. In very sick patients who are septic or have uncontrolled diabetes and so forth, they may require excision after excision if there is an invasive wound infection. and with multiple rounds of allograft, which is not ideal. But so it's case by case.
Okay. Is there any difference for timing of excision for chemical burns like acid and alkali burns?
Acid burns are a little different, but not terribly different. I mean, every one of them is going to be deep burns are different from superficial burns. Acid is different from base, and electrical is also, of course, different. And so ultimately, you're assessing how viable that particular case seems to be based on your clinical experience. I understand there's a large Indian experience that rapid hard excision of a electrical injury does well if you do immediate cover with vascularized tissue, which I think is very interesting that we need to learn from in the United States. So there isn't exactly an easy answer to what you said. I think this is why burn training is so important, and that we need to pass on the nuances of assessing the burn excision to another generation.
Thank you so much. I think we have covered most of it. We have come to the end of this podcast. Thank you, Dr. Fisher. Thank you so much for joining us today and sharing your valuable insights. Thank you for all the listeners for your patient understanding and your time. Thank you so much.
Thank you, everybody.